So this case may likely not be of interest to anyone other than orthopedic trauma surgeons, but maybe some orthopedic surgeons can get something out of it and at least see kind of the thought process behind how we treat some of these pelvic fractures, particularly in the setting of dysmorphism, as is the case in this particular patient. So this is a patient that was struck from the side. The important things to note on this x-ray, that even though it's not a true AP, it's kind of rotated, but it's pretty close. You see the spinous processes, and they kind of line up here with the intact symphysis. So it's a pretty good judgment of rotation. And you see obviously that there is a discrepancy here in the symphysis. You see that the SI joints, which are over here and over here, are not quite symmetrical, and then the iliac wings are not the same width, which speaks to the external rotation of this iliac wing as the SI joint opens wide. So you're suspecting an injury both to the front and the back. Now, I don't have the whole CT scan up, but if you scroll through the axial CT, you will see that this patient also has pubic rami fractures, one at the superior ramus, pretty close here to the acetabulum, and the other one is actually visible right here. No rami fractures on this side, and on the right sacrum, if you again scroll through the CT, which I do not have, but there's a tiny little anterior cortical buckle. So technically, if you really want to call it, this is an LC3 type injury, sort of what we call the windswept pelvis. You've got that lateral compression type injury, and then you have on the left side the APC type opening that happens to also be associated with rami fractures. Now, the important thing to note about this is that there's a couple of ways that this injury can be addressed, starting from, nothing to external fixation, to screw fixation, plate fixation, SI screw fixation, and a lot of it will depend on your discussion with the patient and what you think will be the best for them and what will give them the sort of least amount of risk with the most gain. So when I was kind of looking at this, the LC type of tiny buckle on this side is not really, in my mind, much to worry about. The more important thing is really addressing that SI joint and the symphysis and what happens to it. So the party line for APC, let's call it 2, even though you're never quite sure what is a 1, what is a 2, what is a 3, but certainly this is more than just a little bit of gap. So if you're going to address the SI joint, the anterior gap in the SI joint, which is all this patient had on the axial CT, the party line is that you reduce the front, and that will indirectly reduce the back, and then you can kind of make a choice as to whether you want to put an SI screw there or not. Now, reducing the front here is a little bit tricky because there's an intercalary segment here because of the rami fractures. So if you just pull this part to this part, you're just going to distract through the fractures, and you're not really going to have control of the ilium, and therefore you will not be able to reduce the SI joint. So what you would need to do is really to span the entire symphysis and all these rami fractures and go all the way up here. To do that, which would require a fairly large surgery and may not be the best option if the patient is very obese or very elderly. So the other option you could do, and I did consider this, is perhaps fixing the ramus fracture through some kind of anterior column fixation with a screw, then fixing the symphysis and hoping that all of this together will sort of help pull the SI joint together. The other option is to just address the SI joint from the back and hope that closing down that SI joint from the back will help improve the position of the symphysis. Now, the Inferior displacement here could be partially from the rami fractures, but most likely it is due from the fact that as the SI joint gaps in the front, it also opens up like a book, but not just kind of outward, it opens inferior. So this is pretty common with SI joint opening, that it sags like that. You could say that perhaps if you just put an SI screw into the back and you can reduce it, and you can close down some of that gap and hopefully relieve some of that asymmetry. But you have to keep in mind, and then in terms of your discussion with the patients as well, is that when you do something like that, you really cannot rely on getting a perfect reduction in the front, that it's always going to be a little bit off, because it's very hard to get the SI joint perfect unless you open it through, let's say, a lateral window and really try and get it reduced perfectly. But even then, with these fractures, none of it is really kind of set in stone. The advantages of doing things just directly from the back is that, theoretically, you could convert this APC2-ish fracture to an APC1 and just say that the stuff in the front is just going to heal by itself, and then you have the back under control, and if the posterior part of the pelvis is under control, then you're going to have fairly good stability. And the other advantage, obviously, is that you don't need a big anterior incision. But the disadvantages of that is, number one, it may not be enough to hold it, and number two, the pelvis is not going to look perfect. Now, to my knowledge, if there is a little bit of a residual gap or asymmetry here, particularly in a male, it doesn't seem to affect things very much. In fact, symphyseal plates fail, and it doesn't seem to make much of a difference for many people, even if the gap kind of sort of starts creeping apart again. But that is definitely something to discuss with the patient. So after a while of kind of going back and forth through all the different options, we decided to do an exam under anesthesia, see if this joint widens anymore with abduction and external rotation, which I suspected it would, just based on this one static image. I kind of suspected that I would be able to reduce it by taping the legs together and be able to get some of that symphysis back, and therefore doing an SI screw would be very useful. The other thing to consider here is that this pelvis is dysmorphic. So Dr. Chip Brout talks a lot about the various components of pelvic dysmorphism, and I'm not going to go through all of them, but here the one that you can see the most is the very acute slope of the sacral ala here. So this really makes your OFP, the osseous fixation pathway through S1, pretty tight squeeze here. So I measured it here at its narrowest point, and this is just, like I said, I cannot really scroll through the whole CT here and show you, but suffice it to say that here the narrowest point through S1 is 11.6 millimeters. And when you consider that your SI screw is around 7.3 millimeters, you can put a 6.5, but I try and keep my screws to either 7.3 or larger for fixation. You don't have a lot of wiggle room there, and there's a lot of obviously dangerous things here, and the L5 nerve root is right there. So if you bag that, you can cause basically a foot drop and an L5 palsy, which is something that I discussed extensively with this patient, because if you're going to go this route and you are going to rely entirely on your SI screw fixation to be your actual fixation, you better make sure that you get this right, because this is a very narrow corridor. And I'll show you the little tricks that I took to make sure that I got this right. So here's a 3D CT scan of this same patient, and I chose it to kind of really demonstrate the acute slope of the sacral ala and how difficult it is if you rotate this pelvis around and you try and imagine getting the screw through there, how difficult it is to stay in the bone the entire time. So took the patient to the OR, and predictably, the SI joint opened up and on stress testing, and I thought that it would be worthwhile to put an sacroiliac screw in the back. And so you see the inlet view over here, and some people like to measure the degrees that they think the inlet view will be based on CT scans and angles. I do that just to give myself a sense of how like approximately where it will be, so I can tell the tech, where approximately to angle the C-arm. But for the most part, I just kind of rely on visualization. So in this case, you have S1 overlapping here S2 anteriorly, and then you can see, the dysmorphism of this pelvis, how your pathways are really going to be very narrow going into this this S1 body. The field here is a little too small because the C-arm that I use is actually my partner's C-arm. My C-arm is a little bit larger and wider, but for these particular cases, I learned from my partner to use the smaller C-arm because it's a lot easier to get the various views that you need, because you're tilting down quite a whole lot, and before you know it, you're sitting on the patient's chest or the patient's belly, and having a smaller C-arm helps to get those increased angles that you want. But because of that, the downside is I can't get a wide view, so I kind of have to go back and forth to look at the various points of where I need to be. So, but here you can see the gap, anterior gapping in the SI joint. You can see that pretty well. And the symphysis is not pictured here, but suffice it to say it is off as we expected it to be. The outlet view now here seen on the right. So you need to have your symphysis and your ramus be over the S2 body, which this is the right-sided ramus, and that is technically in the correct position. That is where it's supposed to be. This one is further down, but here are the foramina right here, and this is kind of right below them. So this is reasonable, and you can see the SI joint kind of gapped open here. But so you see this this pathway here, and you can see how narrow things are over here, that you have to sneak your screw across this this foramen. Now, in dysmorphic sacra, the S2 corridor is typically much wider. When I measured this person's S2 corridor, it really wasn't very large at all. He just seems to have a very small pelvis to begin with. But I also felt that putting a sort of a transiliac transsacral screw would just not be in the right trajectory when it came to the fracture, and really what this needed was a true SI screw. So in dysmorphic sacra, there's a couple of things you need to understand. Number one, here on the lateral sacral view, so you line up the iliac cortical densities by shifting the patient sort of back and forth, kind of almost rolling the patient, but you can also airplane the table, which is how I do mine, especially in the bigger patients. And you see, I mean, I only have one representative view here, but you see the iliac cortical densities lining up. In dysmorphic sacra, you're going to see a lot more of S1 above the iliac cortical densities because of the dysmorphism. You're going to see a lot more of S1 uncovered there. And so that's pretty important, because it almost makes it look like you really don't have any room to put an SI screw below it, because here's your inferior limit here, and so where I've put my arrow is, in my opinion, where I should be going into S1. Now, the important part is as you do this, not to go beyond the iliac cortical densities, because you run the risk of injuring the nerve root there. But I think this view is very important. I do know some people do not use this view. They use the inlet and outlet and AP views only, but because I'm still young in my practice, I always get this to double check and make sure that I'm in at least the right place. So as I was saying, with a dysmorphic sacrum, the couple of things to know. Number one, that your S1 pathway is going to be a lot smaller than it normally is. Number two, that your pathway for your SI screws is going to be somewhat exaggerated. So for the trajectory for a SI screw is going to be posterior to anterior. So basically you can see that on the inlet view. And then caudad to cephalad. So inferior to superior. Now, the angles are typically exaggerated when you have a case of sacral dysmorphism. So you see my guide wire going here, kind of heading, and when I do this, you know, I kind of tap the guide wire in a little bit into the cortex so that, because I find that firing the threaded guide wire makes it go kind of like wherever you want it to, and it slips, and sometimes it just completely comes off the bone. So not exactly kind of the greatest the greatest thing in the world. So I tend to start my guide wire by kind of tapping it gently in and then directing it the way that I want. So if I kind of extrapolate based on this line where that's going to be, that looks like you're kind of ending up in the center of the body there. And then here you're obviously staying above the foramina. So generally I'm kind of okay with that. Now here's a trick that I was taught by my senior partner, and it involves kind of what happens with these dysmorphic sacra and trying to sound the bone as you enter the dangerous places. So going back here, when you have this guide wire in right at the level of the SI joint, then you put your cannulated drill over it, and I use like a cannulated T-handle, and you kind of rotate your drill kind of back and forth and back and forth. So instead of doing it on power, I actually do it on hand so that I can very, very gradually make my way into the sacrum and make sure that I am in bone the entire time, that I don't feel myself go in, out, in, because it's almost impossible to feel with a guide wire because your wire is threaded and it just goes wherever it wants. It's very hard to feel on power unless you're really, really good, but it's pretty easy to feel by hand. So I literally advance this drill into the sacrum by hand by just rotating, pronating and supinating my hand a little bit at a time, a little bit at a time, until I reach the edge of the foramen right here. And so once you've reached the edge of the foramen, then you can use your lateral sacral view to double check and make sure that you are not above the iliac cortical densities. And you know, I'm pretty close. And again, this is a very close view because this is a very dysmorphic sacrum, but I am not past it. So I'm good there. And then you can feel free to advance it into the body at that point. And so here's the wire kind of advanced into the body. Now, if you withdraw the drill, and just be careful when you withdraw the drill, make sure, because you've been advancing the drill by hand, you probably got the guide wire stuck inside the drill. So if you just try to withdraw the drill, the guide wire is going to go with you and you're going to lose what you've done. So get another guide wire and sort of use it as a backstop as you remove the drill. So you do that, and then you just have your guide wire left. And then this next view looks like I'm doing something crazy because it looks like I am getting rid of my guide wire before putting in the screw. But what I'm actually doing is I am using the threads as a sound. So instead of basically kind of like you would do a pedicle screw for spine, and I can't believe I'm mentioning spine in this because if I never see another spine, it will be too soon. I'm really scared of those cases. But basically, I'm doing the same thing as a pedicle sound would. So I'm using the threads of the wire to back out, not quite, not all the way out of the pelvis, obviously, but just beyond where the dangerous area is. So just to the SI joint so that I can still find my way back in. And I separate, let's say, I'm basically, it's kind of hard to show you, but let's say, imagine this as your hole and your guide wire is kind of like right here. And so I pick 4 quadrants, and this is what my senior partner told me, or taught me. So you pick 4 quadrants, and then you basically, like, as you pull your guide wire out, you scrape your threads at whatever quadrant you choose. So up at the top, up this side, and this side, and you feel kind of with your threads if you are in bone the entire way through. And it's actually very easy to feel. It's very easy to sound, and it's very easy to feel that, oh yeah, this is definitely in bone the entire way through. So now you have at least two sources of proof that you are in bone the entire time. First is your drill that you've put in by hand, and the second one is your sort of sound with your guide wire. So then once you're satisfied with that, you put the guide wire back in, and then you put your screw in, and then this just goes, this just shows how the screw is going in here, and this is the gap right here in the anterior SI joint, and here it's reduced more than what it was. Now, granted, like I said before, when this whole thing started, it is not going to be perfect, so I'm not expecting the symphysis to be perfect, but I at least know that now I have secured the back of the pelvis, and that is where most of the stability comes from. And then you take your final sort of x-rays, and here it's a little bit dark, but you can see the screw in the pelvis, and you can still see some of the gapping here in the SI joint and some of the gapping in the symphysis, but it's better, it's certainly better than it was before. And now if you look in comparison, you have about 17 point something millimeters and 10 point something millimeters here. So the gaps definitely closed down. Some of the discrepancy here between sort of the sag is also addressed. So if that screw wasn't there and you just saw that, you'd be like, all right, you know, it's not such a big deal. The rami are still kind of where they're supposed to be, and the SI joint is not perfect, but certainly closed down more than what it was. So that's just kind of my my thought process. But again, everybody is a little bit different. Certainly, there are pelvic surgeons who would think that this is sacrilege, and others may agree with me, others may not, but you know, that's sort of the beauty of what we do. And thanks very much for listening.